Hello, I am Michel, a Delft Global PhD Fellow. I work in the group of Professor Kees Dekker in the Faculty of Applied Sciences. My PhD project is to develop a point-of-care diagnostic test that probes for infectious diseases in resource-limited settings. So what are neglected infectious diseases? Let's have a closer look. In the literature, these diseases were previously described as neglected tropical diseases, but given today's international travel, many of these diseases are no longer confined to the tropics, and so we refer to them as neglected infectious diseases. They are called neglected because they typically receive less funding or less research attention from research groups for many reasons, either because they don't affect as many people or too little is known about the disease. So I would like to start with a case study, and for my PhD, I'm looking at leishmaniasis. This is a neglected infectious disease that affects millions worldwide, especially many children. There are three different forms of the disease: visceral leishmania, cutaneous leishmania, and mucocutaneous leishmania. As you can see, the image on the left is an example of visceral leishmania, and this is a fatal form of the disease. So this disease affects the visceral organs like your liver and your spleen, and if left untreated, this disease is fatal. And the images on the right, that is cutaneous leishmania, which is not a fatal form of the disease, but it is very debilitating. So the lesions can be sometimes as big as 4 centimeters wide. And if they occur on your face or around your eyes, you can also go blind. What's very interesting for me is that there is treatment available for this disease, but people simply go undiagnosed. Let's have a look at resource-limited settings. So this is an example of a resource-limited setting in Kitale in Kenya. So Kenya is an Eastern African country, but Kitale is a region on the western side that's very close to Uganda. So as you can see in the image, there is a lack of infrastructure in terms of the way that houses are built and subsequently the way that hospitals or clinics are built. People often have to walk through forest areas, and this is when they are exposed to the sandfly, and the sandfly is what spreads the leishmania disease. So as you can see, women and young children are often exposed when they're simply commuting. This is an example of Building Without Borders, where people went into this village to supply some treatment. And an interesting quote that came out of this blog was that at least 10 people walked as far as 50 kilometers. So this has a huge impact on people gaining access to diagnostics and to treatment. This is typically how treatment is done in resource-limited settings. So as you can imagine, there isn't a central laboratory, there isn't any electricity or a cold chain to store any of reagents. So these are the things that I keep in mind throughout my PhD. So let's just have a quick look and let's compare the two settings. So in the image at the top, you can see a well-defined setting with infrastructure. You have electricity and you have trained clinicians that know how to carry out diagnostics. As you can see, there's a microscope. This is the gold standard for diagnosing leishmania at the moment, is to use a microscope to look at the parasite in a blood sample. But in the image below, this is an example from Doctors Without Borders, where these doctors typically don't have the infrastructure, the equipment, or the time to do the type of diagnosis that is the current gold standard for leishmania. And of course, effective treatment and prevention of these diseases relies on the diagnostic. So the World Health Organization has a set of criteria known as the assured criteria, and this set of criteria basically sets a standard for research groups to adhere to. In terms of affordability, the test should cost less than $10 US. But I would just like to add that many companies right now have tests that cost as little as 50 cents per test. Of course, the test should be sensitive and specific to that disease. User-friendly, which means that people should be able to use it out in the field. It shouldn't be too difficult where you need training. It should be robust and rapid. So the test should get a result within 30 minutes. And in terms of being equipment free and deliverable, for being a point of care test, it shouldn't require any electricity or any infrastructure, but also it should be portable and it should be easy to carry out into the field. So keeping these criteria in mind, we envision a lateral flow assay as our point of care diagnostic test, and the most common lateral flow assay is a pregnancy test. As you know, pregnancy tests are very simple to use. People can even use them at home. So this is a first line of testing. So if you suspect that you have the disease, you would be able to do this test at home. Or if you can imagine, Doctors Without Borders would be able to take multiple strip tests into the field and test multiple people. Okay, so we envision using a small blood sample because this is less invasive. Currently, if you withdraw a blood sample or if you get a bone marrow aspirate for leishmania, then you need a hospital setting and you need somebody who's able to perform these tests. And this is not always possible in resource-limited settings. So we want to go from a simple droplet of blood to a very simple colorimetric readout. So this, again, it's like a pregnancy test where it's just a yes-no answer. It's very qualitative. It doesn't tell you anything quantitative about the disease, but in terms of points of care, this is sufficient. So the key scientific innovation for the DNA detection is to use CRISPR biology. CRISPR is quite a hot topic at the moment, and basically it's a bacterial adaptive immune system. So just like your body has an immune system to protect you from invading viruses or bacteria, CRISPR is basically the immune system of bacteria, and it can directly detect DNA. Just to show you a little bit more in detail, it's a very simple system. It's just a 2-component system with a Cas9 protein and with a guide RNA. And basically this guide is what finds the target DNA. The target would be the parasite, so the leishmania parasite in the blood sample. And the protein helps that guide find the target. And then we want to couple this to a colorimetric readout, which is basically something that you can see with the naked eye, so that you don't need any equipment to look at the results. And in the lab, it looks something like this. So the first sample on the left is just some background. The reagents that we use have a color. The sample in the middle is a negative control, and then the sample on the far right is a positive control. So this would be an example of the color change between a negative or a positive test result. This is the current state of cutaneous leishmania that was published by the WHO, and it shows the number of new cases of cutaneous leishmania that were reported in the year 2013. And as you can see, South America, Northern Africa, and then Southeast Asia are the most heavily burdened. But for many regions, the information is just not available. And this could possibly be due to a lack of diagnostics that's in the field. So just to summarize, my global challenge is diagnosing infectious diseases, and then the local impact would be that we could have more people being diagnosed at the point of care at very low cost. Of course, I do not do this work on my own. This is part of a team. So Dr. Mitasha is a postdoc on the team. Mr. Yako is a research technician. Dr. Gregory Pavlik is also a postdoc in our group, and of course my PI, Professor Kay Stecker. And if you have any questions or any information, please feel free to contact us. And lastly, I will be going out into the field to understand the context. We want to understand current diagnosis in the field. And we are currently looking at Uganda and Kenya so that we can develop an appropriate diagnostic test that takes the end user into account. Thank you so much for your time. That was